from your GI coursework. We'll kind of just go over kind of, not all, I mean, this by no means is all-inclusive. It would take me a lot longer than 2 hours to do all non-traumatic abdominal pain in the emergency medicine setting. So here we're just going to touch on select topics: biliary disease, small bowel disease, and some ischemic bowel intussusception, things like that, appendicitis. That's what it does. Notice I did not say anything, took great restraint.
You turned over a new leaf today.
Anyway, so we'll just go over these briefly. Like I said, these should all be a review. If you see anything, you have any questions, let me know. And like I said, this is by no means inclusive. I didn't do a gastrointestinal bleed or pancreatitis on there. We can briefly go over pancreatitis if we have some time. This lecture's done. I don't have any formal slides prepared, but we can kind of talk about it. If you guys have any questions as far as emergency medicine standpoint. And GI bleed, I think, is a little bit, that'd be too encompassing. I could probably do an entire lecture over GI bleeding and all the small intricacies that go into that. But for this lecture, we're just going to do the ones I have here. So biliary dyskinesia, biliary colic. You know, this is going to be something you're going to see a lot in the emergency department. Just poor biliary motility, poor contraction of the gallbladder, stones, supercontracted bile, things like that. Epidemiology: young, old, women, pregnant, are going to be the ones that have this a lot. You know, pregnant abdominal pain is like a bane of emergency medicine existence, because you can't just go to your old fallback and say, oh, we'll just scan them because they're pregnant. So signs and symptoms associated with this is going to be right upper quadrant pain, epigastric abdominal pain. Sometimes it radiates to the right shoulder, sometimes it radiates to the back. Postprandial pain, pain after eating, usually with fatty foods. So you're, you know, as we all know, your gallbladder holds digestive enzymes that help digest fat and lipolyze it. And so whenever you have a large, big, fatty meal, your gallbladder is going to want to contract to shoot out some more digestive enzymes. And if you have poor biliary or gallbladder contraction or stones in the way that's not letting the digestive enzymes get out, that's obviously going to be pretty painful. Pain starts, steadily gets worse, and then it can subside hours later. It can stay. This is just dyskinesia, so this is not an infection. This is just poor gallbladder motility. Labs, you're going to see a really strong recurring theme with labs and imaging here. You're going to have your same kind of belly labs that we talked about whenever I did the ER lecture last time. And it's going to be your CBC, CMP, and lipase. Imaging, you can do right upper quadrant ultrasound. Your CCK, stimulated cholecystography. Obviously, I can't pronounce that well. That's more of a primary care kind of outpatient type thing to evaluate gallbladder contractility. The CCK stimulates your gallbladder to contract, and you can measure the amount that it spits out and calculate basically what your almost ejection fraction of your gallbladder is and how well your gallbladder is functioning. HIDE-SCAN does the same thing. Diagnosis is made by history, labs, imaging as well. Like I said, everything is a piece of a puzzle. You have small pieces that you need to put together. Treatment, ultimately, you know, you can live your entire life with biliary dyskinesia. There's no reason. I mean, it's going to be painful, but there's no emergent reason to get your gallbladder taken out. If you have continued symptoms, surgery is going to be your ultimate treatment. But until then, you can try a watchful waiting pattern and see if it resolves. Low-fat diet is going to be one of your big things. I always tell people whenever they have these gallbladder-type symptoms, but it's not cholecystitis or anything like that. Their liver enzymes, everything look good, no elevation of white blood cell count. go home, take some pain medicine, some nausea medicine, if there is some nausea, vomiting, and to really harp on a low-fat diet, because any fatty, greasy foods are going to be your ones that are going to stimulate that poor gallbladder tract more. And let me see here. Okay. Cholelithiasis, so this is just stones in your gallbladder. Like I said, this will all be a review. Cholesterol hypersecretion, rapid weight loss, progesterone, obesity, high-calorie diet, fatty foods can be some etiologies of cholesterol stones. There's pigmented stones, and then there's both stone types where you have both of them. There's all sorts of different stony types. In emergency medicine, it really doesn't matter what type of stone it is. It's more of an outpatient GI type thing. More common in women than men, in kind of the 40 to 50 year range, as you can see in this graph here. This is in Europe, but it's going to be close to the same. There's kind of the F's. Do you guys know the kind of the mnemonic thing, the 40 fat female fertile type deal? That's one of the things that are associated with this as well. Is this all kind of review stuff for you guys? Good. So since most can be asymptomatic, you can have cholelithiasis and not have any problems at all. They can just be chilling in your gallbladder and be fine. So this can be a finding that you'll see on CAT scan and ultrasound. That's just a incidental finding and doesn't really need anything to be done about. If they're having lower abdominal pain and you're worried about some kind of small bowel obstruction or something like that, and you scan them and then it shows that they have some gallbladder stones, that's an incidental finding. There's nothing to really worry about them. If they're not having gallbladder type issues, then I wouldn't really worry about it, especially if their labs aren't reflective of it. If they become symptomatic, the symptoms are similar to biliary dyskinesia, nausea, vomiting, right quadrant, abdominal pain, things like that. Ultrasound's the most sensitive. Sometimes the stones cannot be seen by CT, just if they're pigmented right or if it's in the wrong place. And then you can get a CT as well. Sometimes I put right here, usually first line. That's in smaller rural emergency departments where you don't have on-call ultrasound. We have ultrasound during the day, but at night you have to call somebody in, and some of them live in Norman and drive this whole way to get a gallbladder ultrasound. So usually we just go to CT, and that'll be able to show you whether or not they're infected. Like I said, this is mostly just incidental finding, but ultrasound is your best tool for it. Emergency medicine goes, ultrasound, man, I really wish I had more training in it. We don't have an ultrasound machine, so there's really no reason for me to go out and get extra training because I wouldn't be able to utilize it. But bedside portable ultrasound is becoming the mainstay in modern emergency medicine. If you're going to do this, you're going to have to know how to do ultrasound, especially if you work in a large hospital. It's shifting from a paradigm of having ultrasound technicians or radiologists do a lot of the ultrasounds for you. Nowadays, I know a lot of new emergency medicine residents are using ultrasound themselves. They'll walk in with it almost to every patient they see. They'll do bedside echoes. They'll do bedside gallbladder ultrasounds, look for AAAs, bedside DVTs, the whole bit. They'll just literally walk around. It's like a stethoscope now to walk around with a bedside ultrasound. So if you get the opportunity when you're on rotations and stuff like that to learn about ultrasound, to learn how to do these things, to learn the actual mechanics and the physics behind getting an ultrasound, I would definitely recommend that, because that's going to be the new thing to go to, and it's not going to go away, especially whenever we talked about last week that we give, what was it, like 4,000 people cancer from doing CTs of the chest in the United States, average. So ultrasound's obviously non-invasive, no radiation, and is very quick to do. The only thing is you have to be pretty technically proficient at it, so it takes a lot of time to do it, but I would learning about it. Like I said, treatment, nothing unless you are having pain or complications. You know, and then if you are having pain and it's bothering you, and you're having continued nausea, vomiting, things like that, you just go into the general surgeon and get the gallbladder removed. You know, there's not really any stone retrieval or anything like that as you do in kidney stones. There's no shockwave lithotripsy that I've ever heard of. They'll just, you don't need your gallbladder to live, so surgeons like to cut, they'll just go and take your gallbladder out. Complications from having gallbladder stones, though: cholecystitis, pancreatitis, choledocholithiasis, and cholangitis. So those stones, though, can be asymptomatic, sitting in your gallbladder can lead to complications that we're going to discuss later on here. So here is this is a CAT scan right here. So here are the calculi obviously highlighted. They don't always show up like this. Sometimes different stones are muted and they don't see them. But this is what you would see here. And this, I would think, just kind of glancing at this one sliced image of the CT, this just looks kind of like an asymptomatic and incidental finding. You know that the border of the gallbladder is really well defined. There's no pericollic fluid or stranding around this area that we'll see on subsequent CTs. That looks like the gallbladder is inflamed. It does look a little big, though. But these are just some asymptomatic gallbladder stones. And then here in ultrasound, this would be some stones that they see here. And this is the shadowing. This is the kind of pathognomonic thing that you see on an ultrasound. So when you're looking at sound waves, basically, you know, they go down, and then once they hit a solid object or some kind of object, depending on, you know, its composition, they reflect. And so if there's air always comes up black because there's nothing to reflect the sound waves off of. But these stones are obviously of a tighter composition than the soft tissues of the gallbladder and the intestine are, so the sound waves will penetrate deeper into the abdomen, but once they hit these more solid structures, they hit them and then bounce back. That's why they don't penetrate past the stones and you get this characteristic shadowing. So this is not air in the abdomen, this is just the lack of penetration from the ultrasound waves getting through this dense material. So this is going to be what you're going to see on a gallbladder ultrasound if you guys ever do them yourselves. Any questions over those two? I mean, they're pretty simple, asymptomatic type stuff. So chole, did I hear there's a question over there? No, just a cough. Okay. Choledocholithiasis, so stone from a gallbladder that gets stuck in the common bile duct. Your epidemiology is saying it's going to be is a choledocholithiasis, obviously because it's going to be the stone is what gets caught. Your signs and symptoms are going to be, you know, a lot of your non-traumatic GI stuff is going to be your same signs and symptoms. It's not really super fun or that different. It's going to be, you know, nausea, vomiting, right upper quadrant, abdominal pain. What's the physical exam finding for whenever you have pain palpation in the right upper quadrant? Right. So I mean, those are all kind of board question type stuff that you're going to see as well. You can have some component of jaundice if it affects the liver enzymes or have an elevation in bilirubin, which it can. So you can see here, because you guys, I know you all know, like, what's the name of this right here, this little duct? No, this specific one right here. I know you guys know all the branches, right? I'm just kidding. I don't even know if they're actually named. I'm sure they are. But so here's your cystic duct right here, and obviously you can see your common bile duct and your hepatic ducts here. This is where they kind of meet to form and then dump at the sphincter of Oddi into your small intestine. So you can see here with a stone anywhere past, so a stone here in your cystic duct is not really going to cause you any elevation in liver enzymes because this stone to the common bile, or the common hepatic duct and the common bile duct is not obstructed. So liver enzymes are going to flow freely out here with no problem. But once you get a choledocholithiasis, a stone in the common bile duct, you can see by the illustration anywhere along this branch point right here, or not branch point, this common point here, you can see that you're going to have elevation in liver enzymes, bilirubin, possible jaundice, things like that, because of the location of the stone. So a lot of times, you can almost diagnose the choledocholithiasis based on the evaluation of the liver enzymes and symptomology before you even get imaging. But most people, most gastroenterologists and internal medicine doctors and surgeons will want imaging anyways. This is a very big common bile duct with a large stone in the middle that you're going to see on CT here. This common bile duct width, I believe, is typically less than 1 centimeter. So anything over 1 centimeter dilation of the CBD is sometimes reflective of a stone. And like I said, CT, sometimes they don't see the stone there. Obviously, these images I hand-picked to be very obvious, but sometimes on CT, you'll do a scan and it'll make note of a dilated common bile duct, but no stone seen. Just because you don't see a stone on CT, you know, like I said, CT, radiology, it's one piece of the puzzle. Look at your lab work. If you have elevated liver enzymes, clinically significant nausea, vomiting, abdominal pain, you know, you need to go to an ultrasound. And if you don't see it on ultrasound, maybe there are other tests, MRCP, ERCP, you can do those types of things to help figure that out too. Do you guys know what MRCP is? So it's a magnetic resonance polyogram. You can look up the SOCP, but basically you look up, you do an MRI of the abdomen that looks at the gallbladder and common bile duct stones, and there's not a lot that escapes in MRI. You see very well-defined tissues, and then ERCP, obviously, you go in with a scope and snake it back up there, and you'll find it again there. But that's obvious. That's invasive. MRCP is invasive. Like we already kind of hinted on, the key features is elevation in liver enzymes, LPST, ALT, total bilirubin. With the stone, what are you likely going to see? Which should be the highest? ALP, yeah. So a lot of times those are with stones. You can see your AST. Do you guys know the AST to ALT ratios in the differential between, you know, obstructive, viral hepatitis or things like that? You guys reviewed that? Yeah, okay. If we have time, I may pull up another slide and kind of just briefly go over that. That's one of the things that it's easy to forget because you don't use it as often, but it is important. It helps you kind of, when you have because you know, not all nausea, vomiting, abdominal pain, and elevated liver enzymes is a choledocholithiasis or gallbladder problem. There are a lot of other problems just with the liver itself that's not obstructive that can cause those things. And so knowing how to read your liver enzymes and developing kind of a more tailored differential based on those ratios is important as well. Total bilirubin, I think, is, for me, one of the more important ones. You can see a little bit of elevation in your AST, ALT, and obviously an elevation of your alpha phos. Without a choledocholithiasis, if you had a bad cholecystitis, where the inflammation is really bad, you also got to remember how the gallbladder sits. You know, it's not, you know, you guys remember from anatomy, it's not separate and just kind of hanging out there. Most of the times it's wrapped up inside the liver, and so when you got a really bad infected gallbladder, all that inflammation and infection can irritate the liver that it's sitting in and can cause an elevation of liver enzymes as well. But that bilirubin buildup, from what I've seen clinically, is pretty characteristic of the stone. So again, we talked about CT shows a common bile duct dilation. Not the best. Sometimes it does not. We already kind of talked about that too. Ultrasound, better than CT, non-invasive, but like I said, sometimes you rely on the ultrasound text interpretation. A lot of times if it's nighttime or after a radiologist leaves, they don't read ultrasounds like that. It's the next day, so you're kind of relying on ultrasound tech, which, believe it or not, for the most part, are really pretty on top of their interpretations. And here we kind of talked about are about the endoscopic. You guys know about ERCPs? You guys talked about that in GI, yeah. So, you know, not really, rarely used in diagnosis, more in treatment. You know, I guess if you're really suspicious of a stone and didn't see it, you can snake a scope up there, but most of the time that's what they use to go up there and do stone retrieval for. The MRCP, like I said, uses the MRI, it's highly sensitive for these things. Treatment again, ERCP. You can also do laparoscopic cholecystectomy and do an intraoperative cholangiography. So what you do is you'll go in and you'll remove the gallbladder that's full of stones, because it's kind of silly to go up there and do an ERCP, snake out and grab a big stone when your gallbladder is just full of stones. You know, it's just going to happen again. So a lot of times they'll go in laparoscopically, just remove your gallbladder because you don't need it anyways, and then they'll do cholangiography intraoperatively, where they basically just take a catheter, insert it into the common bile duct, and inject radioactive, radio-opaque dye, and then they use a C-arm to look at the filling of the ducts and see if there's any obstruction, and they can remove the obstruction there. One of the complications that you'll see sometimes with post-ERCP, pancreatitis. So you'll get up there and, you know, obviously you're got the scope, it's whipping around that same general area, sometimes can cause you to have a pancreatitis afterwards. So you'll see these people come back to the emergency department, well, I just had an ERCP, and you know, now they're still having the same symptoms as they were. You know, be sure to check your lipase on those patients, because you can have that kind of pancreatitis that way. Any questions on choledocholithiasis? Nope. Pretty common. I mean, this stuff's all super common. I mean, you're going to see, if you work in a large tertiary facility, you're going to see this a lot. Okay, cholecystitis, so inflammation of the gallbladder. Sometimes it can be acute versus chronic, infective versus non-infective. You know, acute usually you see leukocytosis with left shift, fever, infective signs and symptoms, nausea. You can also have a chronic cholecystitis, where it's just chronically infected. You know, you're going to have the same kind of symptoms, right up quadrant, abdominal pain. A lot of times you don't have as much vomiting with these. It's more like a nauseous, painful, like almost like a biliary dyskinesia, but with this one you actually have gallbladder wall inflammation. But you shouldn't really see much of a leukocytosis or the left shift. Definitely not a fever if it is chronic. So how would you differentiate between the chronic? I mean, this left shift, I want to just talk about this a little bit. So we kind of talked about how chronic nausea and vomiting in our last session can cause you to have an elevated white blood cell count. You know, but this left shift, these immaterial neutrophils that your body's pouring out, I don't think are shown as much with just the nausea and vomiting response as you do with an infective type response. So make sure you look at your neutrophil count percentage too. Because this leukocytosis and chronic nausea vomiting, I think, is more just a white blood cell demarginalization type thing, rather than it is a production type issue. Signs and symptoms, again, same as we talked about, can have jaundice depending on if there is a stone causing that, cholecystitis, fever, nausea, vomiting, right upper quadrant, abdominal pain. Labs, same as we did, CBC, CMP, lipase, CT, or ultrasound. Treatment, you do the surgery with or without cholangiography. Some people, you know, in Europe, I think sometimes they're treating these more with just antibiotics and just letting your gallbladder chill out and see if it goes away. Zosyn, the Piptazo, is our go-to antibiotic if you're allergic to penicillins. You can do Rocephin plus Mitrazole, Metronidazole, or Levaquin plus Metronidazole, or also other combination medications you can do. We want to treat the gram-negative bacteria and anaerobes associated with GI bugs. So these antibiotic, just a medically treatment of cholecystitis is going to be for your, you know, 85-year-old grandma who has, you know, end-stage renal disease on dialysis and congestive heart failure and just had 3 stents put in last week. You know, a surgeon's not gonna wanna take that person to the operating room and do their surgery. She's on Coumadin or INR's 5. So these are people you probably wanna try maybe some medical management. But in emergency department, that's really not gonna be your call, it's gonna be the general surgeons. Okay, so here's a CT. So you can see a very big dilated gallbladder here, some cholecystic fluid, and all this kind of haziness here is stranding. Those are all signs of inflammation. I mean, you know, I would say a blind person can be able to see that. You know, most people are going to be able to see that one right there. I always recommend, you know, even though we're not classically trained to read CTs, if you do end up working in emergency medicine, anytime you get a CT, just start reading them, looking at them, and see what your radiologist report is, and go back and see if you can find some abnormalities. It's gonna save you some time in the long run, especially if it's taking 2 or 3 hours to get a radiologist to read your CAT scan, which sometimes it does. You don't want to just be sitting there waiting for a read when you can be a little bit ahead of the ball game. All right, any questions over cholecystitis? Pretty straightforward type stuff, right? Good. All right, so cholangitis. This is the infection of biliary tree bottom obstruction. This is one of the side effects that we talked about with the gallbladder stones. Signs and symptoms, same as cholecystitis, but more pronounced: jaundice, chills, sepsis. These people are sick. Cholangitis is not just your typical cholecystitis. Oh, we'll give them some antibiotics and see how they do, or send them home and then have them follow up with a general surgeon if it's not that bad. These people are sick. These people are close to sepsis. So we want to be really on top of these things. Chills. Body aches, a really high-grade fever, tachycardia, hypotension. Those are going to be some of your other signs and symptoms you're going to see with these cholangitis. These people are pretty sick. So you guys, be familiar with the sepsis criteria. I know we talked about that last time. We talked about how, people don't have to be knocking on death's door to be septic. So know what it is to take and diagnose somebody sepsis, because you really don't want to miss this. If it's an early presentation, you want to catch them before they get to that point. Labs again, ultrasound, CT, ERCP, MRCP, things like that. Treatment can be the same typical gram-negative amaro antibiotics that you typically do for GI stuff: Zosyn, Rocephalin, Metro, etc. Like I said, look out for sepsis. Lactic acid, procalcitonin levels. We talked about procalcitonin last time. And actually, I need to take this out here. I was just, man, everything in medicine changes all the time, and I swear it changes like month to month. It's ridiculous. So I was really on top of procalcitonin for a long time, using it a lot. I saw a lot of my colleagues using it. I've read some good research about it. And now they just came out with a paper that really looked at procalcitonin and its ability to differentiate between a viral infection or a bacterial, and it was like worthless. So I think its sensitivity and specificity were in the low 70s, high 60s. They did the study against the emergency medicine physician's clinical gestalt, so basically his gut feeling about whether or not this person had a bacterial infection or whether or not this person was septic. And then they looked at that versus the procalcitonin score, and through the magic of statistics that are above me, they found that the gut feeling of the ER doctor had a greater sensitivity and specificity than the procalcitonin did. So I don't know. And maybe next week they're going to come out with a paper that says procalcitonin is a cure for cancer. So, it changes all the time. But I still think in clinical practice, people are still using it, internal medicine doctors, ICU doctors. So it's still something that you want to get. But this thing in and of itself is basically telling you need to stay on top of the literature. Even whenever you graduate, things change all the time. Perforation is a higher rate because of the worsening of infection. And obviously, when they have a perfed abdominal organ, you're obviously going to go to the emergency department and need big time washout, you need big time sepsis and die from these type of things. Any questions over biliary type stuff? I'm going to move to small bowel. We good? I told you this one's going to be quick. You guys don't mind getting out early, do you?
No.
No? We can stay a little bit later.
No, it's all right.
Okay. Yeah,
Hey.
Dr. McNeil would like, I have some other lectures that I'm developing we can kind of go through too. The appendicitis, very common inflammation or infection in the appendix, most common cause of eccolith. It's one of the most common causes of acute abdominal pain as well. Epidemiology, so most common prevalence in the second and third decade of life, but it can happen anytime. I've diagnosed a 7-year-old with appendicitis, and I've diagnosed a 97-year-old with appendicitis. It's kind of one of those things. A note of it though, it is difficult to diagnose in children. You know, kids present to the emergency department with abdominal pain all the freaking time. And it's so difficult because, like we talked about before, you can't just go, well, give them a line, labs, and scan them. You know, you not want to, it's, your ER nurses are going to become very angry at you if you're ordering IVs and fluids on, you know, 4- and 5-year-olds all the time. Because one, it's very difficult to obtain. 2, they're not the most cooperative patient. And 3, a lot of times it's not even needed. There's a lot of other causes of abdominal pain in young children that's not appendicitis. So it is difficult to diagnose, but I can say this number, yeah, I'm trying to pull it off the top of my head. I'm going to put it in my lecture slide next time, but I think like 5 and under is pretty uncommon to have an appendicitis. Go back and go to update and look at that number, just double check, but I think 5 and under is, I mean, it's a pretty, I mean, it's like a 2 or 3% chance of actually having appendicitis at that age. Okay, so classic presentations is going to be periumbilical abdominal pain that localizes to the right lower quadrant over time. Burning point tenderness, nausea, vomiting, fever. Symptoms usually get progressively worse as they go on. So one thing would be you really want to worry about pain that's very intense and then all of a sudden goes away. What does that mean? Right, they perf. That's typical what happens. So pain is just intense. All of a sudden, you know, then they're in the emergency room. It's like, oh my God, it's completely gone away. I feel great. Okay, we'll go home. We don't need to do that CT scan. No, you still need to do it. So those ones are going to be the ones that rupture and pain goes away. But then all of a sudden, you know, a couple hours later, they're going to be septic and have peritonitis and end up dying. You know, labs, same as again, CBC, BMP. You know, why a BMP on this? Why did I put that there? As opposed to getting a CMP, I should say. So what's the difference between a CMP and a BMP? Should you have, I mean, you really shouldn't have elevation of liver enzymes with appendicitis, correct? They're separated by a relatively large distance and not connected really in any way. That's going to cause problems. You know, some people will harp on you about this. I'm, in my old age, becoming more relaxed on the ordering of BMP versus CMP. Not really, especially for undifferentiated abdominal pain. I think it's appropriate to go ahead and order CMP because, you know, those hepatic enzymes are one of those things that you're not going to get on any other blood test. So, like we talked about last time, if you don't get it, you don't see it, you don't diagnose it. So CT, ultrasound, may have to use triple contrast to skinny. You guys talked about that? Mm-hmm. Yeah. So I think the rectal tube full of contrast are going to be their favorite doctor. Surgery, antibiotic, Zosyn, but not just Zosyn, the other ones we talked about, the gram-negative anaerobes, you're going to use to treat. That one's kind of a slam dunk. Any questions about acute appendicitis?
Is the treatment the same if it's perforated?
I'm sorry?
If it's perforated, is the treatment the same?
Yeah, the antibiotics are going to be the same, and then the surgical treatment is going to vary. It's obviously not going to just be go in there and take the appendix out. You're going to have a huge abdominal washout to make sure you don't get the peritonitis, and then you're going to have to stay. Some people come in with appendicitis, get it taken out, and if they're young, healthy, have no problems, they may go home the next evening. Just a one-day stay. It's a very, it's a very common procedure. It's performed a lot. It's a low risk of complications. But for a ruptured appendicitis, those people are going to want to stay in the hospital longer, trend labs, and monitor them a little bit closely because they're going to be very high risk for peritonitis. Because whenever there's a lot of surface area within the abdominal cavity, there's a lot of places that bacteria can move around, and if your washout isn't as thorough as it needs to be, peritonitis is a very high likelihood. Okay, diverticulitis occurs from an infection and subsequent microperforation of diverticula. So a lot of people will have diverticula and not ever know it until you get scoped and or scanned. About 25% of people with diverticulosis will get diverticulitis. That's one of the questions that I typically ask people. In emergency medicine, it's patients are difficult, and you're seeing them when they're obviously in pain or distressed or distracted, and not everybody, is a rocket scientist. When you go in and talk to them, you're like, well, you have any medical problems? No. Well, what are these 20 medications that you're taking? So this is one of the questions that I'll ask people that are having abdominal pain. Have you ever been told you have diverticulosis or anything like that? They're like, what is that? And I just say, well, if you never heard of it, then you don't have it. Or never been diagnosed with it. Typically, you're older adult. The mean age is 63 years of age. So, clinically, I think the people that I've seen, that seems a little bit old, but that's what the books say. So you'd be your older adult is going to be the one that gets these. So classically, it's going to be left lower quadrant abdominal pain, but not always. It can involve the right lower quadrant. It can involve the cecum at sometimes. Nausea, vomiting, diarrhea, fever, blood in the stool, so you get a rectal guaiac to check for blood in the stool. These microperforations will cause you to have that occult bloody positive stool. Again, the same labs. Like I mentioned, don't forget about the stool hemoccult. That's going to be important. CAT scan is kind of the mainstay to diagnose these people. Gastroenterologist is not going to do a colonoscopy and scope anybody who's acutely ill. That's just setting somebody up to get their large intestine perfed. So CAT scan. Would you do that with or without contrast? It's with. You meant my general rule of thumb these days is give everybody contrast except for your selective rule out quick CTs of the head for strokes, and if you're like damn sure positive that that's a kidney stone you're looking at, most everybody else is going to need to get contrast. What would be some reasons that you would not want to give contrast to somebody? Kidney function.
Allergies.
What allergies are we looking at?
Iodine.
And
Barium.
you have to say it louder. I can't hear.
Barium.
Barium. Maybe. I'm not going to say no. I'm going to be nicer and say maybe. I don't know.
Is there,
Maybe.
is
I don't
there
think
like
so.
a indication not giving it when they're on metformin?
Not necessarily not give it, but you'll want them to hold their metformin dose for 24 hours.
Okay.
Yeah, that's a protocol written in on a lot of radiology texts. They are on metformin, they'll hold their metformin dose for 24 to 48 hours. That's a good idea. I'm looking for one more thing. It's associated with an allergy, but it's not iodine. I thought I heard somebody say
Shellfish.
shellfish. Yeah. That's kind of a relative contraindication. You know, there is some clinical correlation between shellfish and iodine having the same allergic type reactions to it. But, you know, that's gonna be up to, I usually let the a radiologist make that call. Looking at their previous scans in the past, see if they've had iodine in the past. So kind of as we're talking about this, I know we're gonna get done pretty quickly, and this isn't in my CAT scan, but I think it's important to know. Or it's not my lecture, but it's important to know as well. As far as getting contrast for abdominal CAT scans, what if somebody has an allergy to iodine and their reaction is non-anaphylactic? So it's like, well, I get some hives and I start itching, or, you know, makes my teeth hurt or something like that. What can you do if somebody has an allergy to iodine but desperately needs not the scan, but needs the contrast material, the IV contrast?
Should we desensitize?
Do what?
I thought we learned one time that you can desensitize.
But
But you can give them antihistamines.
Right, yeah, you can't, I don't know if you can desensitize. I mean, I guess you could really desensitize anybody. We don't have time to desensitize in the emergency department, but somebody else said it. Benadryl, yeah, anything else, just Benadryl? Pepsid, and then Benadryl, Pepsid. Is Benadryl antihistamine?
Yes.
What's Pepsid?
Ranitidine?
And what's Benadryl? Okay, so you guys are saying Benadryl, an H1 blocker? It's the same thing. But good job, I'm glad you guys are learning. Isn't this?
Shut up. This is silly. I can't handle this nice anymore. I'm over it.
Okay, one more. I mean, it's your standard, like, allergic reaction type things you throw at people.
Epinephrine.
Epi? Okay, I gotta be nice. No. Steroids. Steroids.
Oh, it's like steroids.
Steroids. So this is, it's termed a lot different in a lot of different places, but I've seen it mostly it's called a Greenberg protocol. I think it was developed in some hospital in Pittsburgh. It's called the Greenberg protocol, and it is it's dosing of Benadryl, steroids, and Pepsid to kind of inhibit that the allergic response. But that's not just like, oh, well, let's give them a little bit of steroids and Benadryl right before they go to CAT scan. It's like a 6 to 8 hour process versus on multiple doses of medicines to be able to get you to do that. So, you know, can you think of any CAT scans? I know this is kind of off the subject of GI, but I'm thinking about it and I want you guys to really drive this home. What kind of CAT scans could you be ordering that are contrast specific, that you need contrast to be able to make the diagnosis, that if you scanned them without contrast, you would not be able to see this pathology?
Like an IVP?
I'm sorry?
Like an IVP?
You're saying intravenous pyelogram? No, just a CAT scan, not that one.
Would it be like a bladder perf, or can you do?
Yeah, a bladder perf could be one of them. You'd see the contrast leak out of that. That could be one. Usually with bladder perfs, what you'll do is you'll do a retrograde. It's kind of a retrograde pyelogram, but it's not going to be a CAT scan. That's going to be, they stick a urinary catheter, and that's going to be with a fluoroscopy. You're going to have a big C-arm over the top of the patient. You're going to have somebody at the bedside push it and then shoot those directed things, and you can see it spread out or not fill the bladder. That's not necessarily going to be. You can see it sometimes in a CAT scan because they'll do the delayed images where the contrast media will sometimes go to the bladder, but most times if you're looking specifically for a bladder rupture, you're going to do that fluoroscopically. You guys think of any CAT scans where you absolutely need contrast to make the diagnosis. And specifically the chest area. PE would be one of them. What's another one? Two of them I can think just right now that I'm thinking really off the top of my head that need to be drive home. And aortic aneurysm or dissection. You're not going to be able to see a true, you can see the aneurysm on a CAT scan without contrast because you can see the aorta and they can measure the cross-sectional diameter without it, but you're definitely not going to see the dissection. You're not going to see the contrast material leak out of the intravascular space and kind of plane out through those layers of the artery. So if you're having somebody that is having chest pain, they're 65, it's radiating to their back, but they have an allergy to contrast, that would be, if it's just a non-anaphylactic reaction, that would be something I think that you would want to look to get an Greenberg protocol on. Okay, now we'll go back to here. I know that was kind of a big jut out there. Diverticulitis, so treatment, medical versus surgery. Surgical is usually just mostly if they perf diverticuli or if they have an abscess or phlegmon. You can see this word used a lot, phlegmon. It's just a collection of infectious material. And I looked at CAT scan reports all the time. I was like, what the hell is a phlegmon? And I think I Google it 90 times until I figured it out. So it's kind of like an abscess. So inpatient versus outpatient. So what kind of antibiotics is the standard of treatment for somebody for diverticulitis? I just heard one of them.
Cipro or metronidazole?
Yeah, don't be afraid to speak up.
Metronidazole.
Good. And Cipro. Those are good anaerobic and gram-negative medications. This is the one of them that I don't think really changes between inpatient IV and outpatient oral antibiotics. When they're inpatient, they're still going to get ciproflagyl IV, and if they're outpatient, you're still going to get them ciproflagyl orally. So kind of this inpatient, outpatient thing, diverticulitis isn't necessarily something that you need to come into the hospital for. If your pain is under control, your symptomology is manageable, and your vital signs all look good, I think those are people I send home all the time on oral ciproflagyl and have them follow up with the primary care doctor in 48 hours to make sure they're better, and then again in a week to make sure symptoms have resolved. But these are all kind of pieces of the puzzle here. Probably not going to send that 90-year-old with diverticulitis home, but you have somebody who's youngish in their 40s or 50s, have diverticulitis, their white blood cell count is not super impressive. It's not like 30,000 or anything like that. They're not tachycardic. They're not vomiting up all over the place. They don't have any blood in their stool. I think those people are candidates to go home. Treatment, here we go. Even though Zosyn right here on inpatient is Cipro, Metro is going to be your go-to for them. Like I said, surgery consult if it's an abscess or perf. Everybody, I hope it's been driven home to you that abscesses, don't really respond very well to antibiotics unless you drain the abscess in some way. If you catch it early enough, sometimes they do have resolution, but if you have an abscess diverticuli, you're going to need to get that drained. Sometimes they can go up and do that laparoscopically, and sometimes I've seen them do it via ultrasound guided, percutaneous, like through interventional radiology, they'll go in and use ultrasound, or they'll do a CT guided drainage, and you don't have to be opened up or taken to the operating room. So here's CT, this big diverticuli, all this stranding here. This is what you're going to see. What side of the body are we looking at right here? Left. No. It's backwards on CTs. You're looking at them. Whenever you look at it, you're looking at it backwards. So left, right. hard to orientate yourself on this because there's no really abdominal organs. You know, it's easier to say when you have this gigantic liver up here, you know. All right, intussusception, you guys talked about this during pediatrics, right?
You haven't had any.
What?
We haven't had peds, but I've briefly mentioned in
Oh, okay.
GI.
Okay. Well, we're still gonna be out pretty early, so we can just talk about it real quick. So this is invagination or telescoping of part of the intestine into itself. Typically occurs in the ileocecal junction. This is more of a pediatric diagnosis. Not gonna see this a whole lot in adults, but I mean, obviously it can happen. Most common abdominal emergency in early childhood, particularly in patients younger than 2. It's usually in 6 to 36 months, the most common age. Man, this is something, like I said, this is something that's easily missed, especially because it happens at 6 to 36 months and around the age of 2. I mean, those kids, they can't talk, they can't tell you what their symptoms are or anything like that, so these ones are difficult to diagnose. So your classic triad is what you're going to see on your board exams. You get abdominal pain, a sausage-shaped mass, and red currant jelly stools. Memorize the sausage-shaped mass and red currant jelly stools. You know, that's when you see red currant jelly stools equals intussusception. I mean, that's a board question that you should think all of about 3 seconds on, and then go to the next one. These ones, that's pathognomonic. Now ask me how many times you actually see red currant jelly stools. Yeah, rarely often. When you get to this point, so what do you think is causing this red currant jelly stool? Is it just like a cool new enzyme that's created that turns their stool red and jelly-like?
Is it auto-digestion? Maybe?
Kind of on the same path. There's not a lot of digestive enzymes, I think, in the small bowel or stomach acid that's going to digest itself, but you're kind of close.
Necrosis?
Yeah, necrosis. So this is going to be invagination of the small bowel into itself, and that will cut off blood supply to that area, and then you're talking about necrotic tissue within the small bowel itself, and then that's sloughing off and coming out, and that's what's causing that. So once you get to the point you're like, oh man, I see some red currant jelly stools, that's bad. That's a bad sign. That kid has some necrotic bowel, is probably going to lose some of his small intestine, because once something becomes ischemic and starts dying and necrotic, I mean, you can't reverse that. You know, once it's dead, it's dead. So don't be dependent on this sign. Don't do a stool guaiac and say, oh, that's negative, it looks fine. That's not an intussusception, that's a very late sign. You know, this sausage-shaped mass, you know, I dare you to try to do a great abdominal exam on a kid that's screaming and in pain and moving around. You can't feel shit on that thing, so good luck trying to find it. But this is going to be on your board questions. This right here, so obviously I capitalize this for a reason because I think it's very important. And you know, if I were director of this program, I might make a test question over this.
As I'm doing right now.
So this whole thing is intermittent. That's the big key feature of this intussusception type pain. This pain is intermittent. It comes and goes. So whenever you see a family member that brings in their kid and says it's like his pain, he's just bawling. You can't console him. He won't even let me touch him. His knees are drawn up to his chest and towards the abdomen, and it is just painful. It's like I've never seen, and these mothers are freaking out because they've never seen their kids in this much pain before, and then all of a sudden, you know, they're normal. And they have no pain. And they're running around the emergency department like a chicken with their head cut off, and you're like, that kid is not sick. He's doing cartwheels and backflips off the triage desk. You know? And then all of a sudden, bam, it comes back, and it's incredible pain, and they're, you know, it's that intermittent, this episodic nature is what's pathognomonic for the intussusception. So it's one of those things, like I said, if you don't ask that question, you're not gonna get that answer. Parents don't read the book, they're not gonna freely admit. A lot of parents, unfortunately, it makes our job harder, are really worried about their children, that they have something wrong, and so they will kind of artificially conflate these symptoms to make it appear worse than what they really are, because they want you to know that their child is sick. So they're not gonna freely admit, like, oh, well, he was running around fine for like an hour and he was okay. You know, they're gonna be like, he's hurt and he's, you know, he's dying, blah, blah, blah. So you need to make sure and ask, are there any times or periods where this pain goes away and they look fine and then it comes back? That would be something, that would be very concerning. And this knees to the chest or draws legs towards the abdomen, another board question type thing on a kid. You should read that, you know, and then immediately answer the question. It's kind of one of those things they have like this, you know, 3-paragraph vignette, and you can read those questions and then skip the rest of it and go answer. I wouldn't recommend that, but you know, you can. So episodes usually last 15, 20 minutes. So these intermittent episodes, what do you think they're from? Not really peristalsis, but it's the small bowel invaginating in and out of itself is what's causing. So when it goes in, and the intussusception, that's when the pain, and then it kind of comes loose, and then it goes in. And so what happens is that inflammation becomes so great from kind of that in and out type motion of the small bowel, that the bowel becomes inflamed, and then all of a sudden, once it goes in, it becomes so inflamed that it won't come back out. And then that's when you have the loss of vascular supply and red currant jelly stools, and that would be a really bad late sign. Nausea, vomiting, bilious versus non-bilious, depending on whether or not the bowel's obstructed or not, if it's kind of the late one. Imaging, so ultrasound method is the method of choice. That's how you diagnose these things. It's difficult because it's a difficult ultrasound to perform. It's on a young child. Our ultrasound technicians in the Mercy facilities, not just my hospital, even in Oklahoma City, our main hospital, they don't do abdominal ultrasounds on children for intussusception. We have to send these kids to Children's Hospital or Integris, where they have, where the ultrasound techs are experienced in this. Your classic finding is going to be a target sign or a bullseye. So when you think about the small bowel going into itself, you're going to have one of the larger segments on the outside that's creating the outside ring, and the part that's actually invaginating is going to create the inside ring. That's that bullseye. A CT scan can show it sometimes, but not as reliable as ultrasound. And like I said, you really don't want a CT scan a 2-year-old as much. Treatment, non-operative reduction. So this hydrostatic saline or contrast or air enema is diagnostic and curative. Can be under fluoroscopic or sonographic guidance. They kind of sneak a scope up there, and then they inject some contrast or air and open up and de-invaginate, I just made that word up, de-invaginate intussusception. So complications, like we said, venous to lymphatic congestion, ischemia, perforation, peritonitis, things like that. Those are, these are one of these things that you need to think of. Any questions over intussusception? I'm sure you guys are going to have more about that in pediatrics, but this is kind of your down and dirty ER type thing. All right, ischemic bowel. So any process that reduces the intestinal blood flow, arterial occlusion, venous occlusion, vasospasm, things like that. 67% will cause acute insufficiency of the mesenteric arterial blood flow. Mesenteric ischemia is going to be the biggest cause of it. Do you know which section or branch point of the abdominal aorta that feeds the mesentery? Or what are the 3 branches of the abdominal aorta? it's really embarrassing because your anatomy instructor's like sitting right back up there.
The celiac,
Celiac,
superior mesenteric, and inferior.
inferior, yeah, so your superior and inferior mesenteric arteries that are big branch points, that can cause, that can get clots in it, that would cause this